Hello, everyone. Thank you so much for joining us today. This is Stuti Chakravarti, and I'm one of the Harvard Public Health Review Fellows. And the name of my blog is Stroke Reimagined. And today I am really honored and really glad to welcome Dr. Sureshkumar Kamalakannan, who has been a true inspiration and a mentor for me. And I'm going to introduce him now. So Dr. Kamalakannan, thank you so much and welcome to this small vlog that I'm doing. And to be very honest, when I was thinking about possible researchers or people working in stroke and low and middle income countries or disability related research, the first person that came to my mind was definitely you, especially because you have truly been a mentor to me and you've been such an inspiration and you're so approachable as well. So thank you so much. I know that you keep really busy. So thank you for doing this.
Thank you, Sudhi. Thanks for the opportunity as well. Would love to talk about it.
Great, thank you. So Dr. Kamalakannan is an academic researcher with expertise in occupational therapy, public health, disability, and epidemiology. He's also an early career fellow in clinical and public health for the DBT Wellcome Trust India Alliance, evaluating the effectiveness of a technology-enabled educational intervention for stroke survivors in India through a clinical trial. He's also a visiting fellow for the International Center for Evidence in Disability at the London School of Hygiene and Tropical Medicine. And he's also currently co-investigating a project funded by the Medical Research Council of UK to develop a stroke caregiver intervention for strengthening health systems in Malaysia, and also an NIHR funded research related to promoting UHC or universal health coverage for stroke survivors in South Africa. So he has been doing extensive work related to stroke and disability intervention in low and middle income countries. He's also a systematic reviewer and contributes to the Cochrane Collaboration and Cochrane India Network. And Dr. Kamalakannan and I share similar roots, as in we started out as occupational therapists, clinicians, and in fact, he worked quite a while back, the same college and institution that I graduated from. And he has made a paradigm shift in terms of his career from a clinician being an occupational therapist, and has really been a true trailblazer for disability-related research in India and other LMICs. So thank you so much, Dr. Kamalakannan. Would you like to say anything as a starting point?
Thank you, Sudhi, for the elaborate introduction to me. I would basically like to say that it's really a good thing that whatever you're doing in terms of this particular work. I definitely think stroke is an important area that everybody has to know, especially in terms of tertiary care and tertiary levels of prevention. And as OT, whoever thinks about the clinical aspects, it's actually very good to know that somebody who is trained in occupational therapy is now moving towards public health and disability exclusively. So I'm very glad that I'm part of this opportunity. Thank you.
You're welcome. Thank you so much for joining, sir. So I have a few questions that I will get straight into. So the first question that I would really like to ask you, and I'm sure our audience would also like to know, is you started off your career as a rehabilitational professional, that is an occupational therapist. So could you tell us a little bit more about what sort of motivated you to take up research related to disabilities in low and middle income countries, or more specifically stroke-related research?
Sure, of course. So the start point of me thinking about doing something related to health and disability is a part of what I experienced in my early years of learning. I grew up in an environment which is very difficult, and the environment is actually the clear-cut environment of not so good for somebody who's disabled. So we can see social stigmatization, we can see lack of opportunities, we can see people discriminating just because you're disabled. So I grew up in that environment, and right from the beginning, I thought something I should actually do for people with disabilities, even before I started thinking about finding a place in a school for occupational therapy. But once I started to learn occupational therapy, interest was actually shifting towards clinical practice and more into the science of occupational therapy rather than disability. And at that point of time, I would say soon after my graduation, the experience that I had, especially practicing occupational therapy in a place which is one of the best in South Asia, I would say, Christian Medical College, Vellore. And it gave me lots of scope and opportunity to engage, learn, and then understand disability as it is, rather than looking just at occupational therapy. So it's not about just doing what you learn, but also looking at whatever is possible outside the ambit of institutional rehabilitation. And over a period of time, I learned that this is the similar context in almost all the low and middle income countries, not just in India. However, India is the second populous country in the world, so there's special focus, and I'm quite bound by that focus. So I like to work in India a lot because there's too much of needs for somebody who can contribute to disability. However, the understanding that I got was it's the same. Whatever I have in India is what is actually available in lots of low and middle income countries. The resources are very limited. The access to physical rehabilitation service or rehabilitation service for anybody with disability in general is very, very scarce in these contexts. And hence I thought I should actually focus my career building something and then trying to look at mainstreaming disability within the agenda for health in low and middle income countries. With respect to stroke, amongst disability, if you see what is really impacting a lot globally, it's only stroke. So stroke has been the leading cause of death as well as disability in the past 3 decades. It's not just 1 or 2 years. It's been ranking 2 for both mortality and morbidity. The whole world is actually is kind of experiencing stroke as a massive burden of non-communicable disease. And this is something related to disability as well. So once you look at non-communicable disease, the global focus is on non-communicable disease at the moment. We have moved epidemiologically from communicable disease to non-communicable diseases. However, when you look at what is more disabling amongst the non-communicable diseases, stroke is a kind of clear-cut example of how one can experience permanent disability due to stroke. And the impairments that's caused because of stroke are not just very physical in nature. There's cognitive impairments, and there's psychosocial impairments. There's also kind of visual impairment. So all kinds of impairment is mixed. So the disability experienced by somebody who survived a stroke is much, much more severe compared to somebody who's actually experienced any other kind of disability. And the focus of the world on looking at helping people with stroke has only been within the acute stroke care and also within the hospital setting globally. And in low and middle income countries, there's no question about lack of community-based follow-up and rehabilitation services for people who are affected by stroke. When you have a massive magnitude of a problem and when there's no focus on tertiary prevention or rehabilitation, I think that's the best area where I can contribute, and hence my focus is on stroke and in low and middle income countries, and also on preventing disability among stroke survivors.
Thank you so much for that insight. I could relate so much to all the things that you said, especially because currently I am practicing in the same place where you started off, and it has really given a lot of insights into the kind of challenges that need to be addressed, and really thankful for all the work that you're doing in this field. I guess the next question that I had for you is, a lot of the current literature, if you look at it, has been repeatedly emphasizing on the importance of a multifaceted and transdisciplinary approach towards the treatment of stroke, especially when it comes to low and middle income countries. So why has this not yet been implemented successfully? And just to follow up to that question, if you could just shed some light into what are the challenges at the healthcare policy level that probably contribute to this?
Right. So if you want to look at management of stroke-related disabilities through a multidisciplinary or a transdisciplinary team, you talk about transdisciplinary team or interdisciplinary team when you don't have enough expertise to actually very specifically focus and then provide a very good, comprehensive, holistic rehabilitation with multidisciplinary team. So when you don't have multidisciplinary team, you start thinking about, okay, can we actually have somebody else who's not exactly the person to provide that particular service, but somebody else can add on to it and then kind of support in the absence of another professional. That's how you start thinking about it. But when you look at it as a public health problem, the focus should be on a system that is there to provide health, not only health, but also social care. And that system is missing in most of the low and middle income countries. And it's not very well developed in some of the high income countries as well. So when you look at public health perspective to come to do something and to reduce the burden of disability through that's kind of contributed through stroke, we have to look at, is there a system in place first to accept that yes, we don't have a system. And in most of the low and middle income countries, the perspective is still looking at the medical aspects of disability. They think if we actually medically stabilize a person who survived a stroke, we have done whatever we are supposed to do. However, that's not the end of the story. When you look at comprehensive healthcare, when you look at universal health coverage, when you look at sustainable development goals, everybody talks about leaving no one behind, including persons with disabilities. But this happens only on paper in most instances. And that's been the kind of scenario in most of the low and middle income countries context. And this scenario has to change. If this scenario prevails, what we can actually have is lots of national programs related to stroke in many of these contexts. However, the focus will be only on institutionalized acute level of care and rehabilitation. And that's been the case everywhere till date. So I still stress the importance of whatever you ask. So basically, rehabilitation for stroke survivors have been a major issue, but the whole world talks about stroke as a major issue for 30 years. And they're still not actually including a comprehensive rehabilitation package for those surviving a stroke within the national programs of their own countries. And especially looking at what a stroke survivor can get from the system once they get discharged from hospital. So in terms of policy levels, it is kind of a straightforward link to what I just said. So we do have tremendous good level, very well operationally defined policies in most of the countries for stroke care. They talk about rehabilitation, they talk about different kinds of specific systematic techniques that can be used. They talk about insurance for people affected by stroke, assistive technology. It's all there on paper. But when you look at what is operationally possible and how they are implemented in real life context, there's a big question mark. So for example, in India, you have this national program for control of 4 different conditions which are non-communicable. So cardiovascular diseases, cancers, stroke is one part of it. And when you look at all these non-communicable diseases, and when you look at the national program considers all these 4 non-communicable diseases as a one disease. They think that one specific strategy, for example, early detection and treatment is the same for everything. However, I kind of disagree with that phenomenon or definition, because the early detection and treatment for cancer can be entirely different from early detection and treatment required for a stroke survivor. And that's how the policies are currently placed and implemented. And also, since 2006 till date, there has not been any monitoring and evaluation of these national programs, let alone stroke, but for all the non-communicable diseases, we do not have a monitoring report as of yet in India. It's either state-wise or complete national-wise. And I think this is very similar when we look at other countries like Brazil, Russia, and South Africa as well. So policies are there. Implementation-wise, there's a big inefficiency. It's only because there's no systems in place for social care and disability management in most of these low and middle income country settings.
I think that was a really, really good insight. I didn't know this actually, that it hasn't been really looked at since 2006. I think that is a major challenge. And like you rightly pointed out, there has to be more accountability. There has to be more systems in place in order to get whatever is on paper to actually benefit people who've had stroke or who are at risk of developing disabilities. So thank you for that insight. The next question that I had was, so this is quite important for me because, you know, I'm just starting out with my career. So I think there are many people who are watching this who also would like to know what can future healthcare and rehabilitation professionals do in their own capacity in order to strengthen systems of stroke care in low and middle income countries. And again, following up on that, what are some sort of, what are the gaps that need to be addressed for the future? If you want to shed some light on that.
Great question, actually. And I'm sure my career experience can set the best example for somebody who wants to contribute to stroke care in low and middle income countries. The first and foremost thing that I would suggest any people with enthusiasm and passion for this to do is try and define disability for yourself. So what do you think disability is? Is it just because you see somebody who cannot move their hands or legs disabled? Or do you see somebody who's got an extra toe and who's unable to get married because of that extra toe for about 10 years or 15 years from the right age of marriage? Is that a disability? So disability has to be conceptualized by somebody who wants to contribute to disability. So that's the first thing that I would suggest anybody who's passionate to contribute to disability would like to do. So disability is not related to impairments alone. So it is not equal to impairments. There's much more complexities and science behind impairments in terms of activity limitations, participation restrictions, where exactly the person actually experiences these participation restrictions. How is he as a self, as an individual? Does he have good self-esteem? Does he have social support? Does he have family support? All these are actually kind of very, very important when you look at conceptualizing disability in any society. And when I say contextualize, the word context also matters a lot. So you have to understand the systems in place. So that's the second suggestion that I would say. So just because you've finished occupational therapy or just because you've just finished a doctorate in disability doesn't mean that you know everything. Contributing and implementing a science is completely different to learning a science. And when it comes to implementation, unless and until somebody understands the system that you're working with, it's very difficult to implement. So understanding what system is actually available is very important. So in a context like India, if you want to contribute to disability, you can very well question why there's only 4 professionals called rehab professionals according to Rehabilitation Council Act. There's no OTs and physios in the Act. And it's not been replaced since the beginning when it's actually, the Act was passed. Since then till now, we do not have OTs and physios within the Rehabilitation Council Act. And there are other examples as well in terms of how do you evaluate disability and then provide people with a disability certificate. You talk about social security, you talk about who is disabled, who is not disabled, and you actually categorize somebody as disabled based on the impairments only in an Indian context. So if somebody has got one hand, then you will get 50% disability certificate. If somebody has got one finger gone, you will get 20% disability certificate. This is how disability is actually evaluated in a context like India. However, that's not disability. So you're looking at measuring impairments only. I might not have 2 hands, but if I'm actually perfectly independent and I'm leading a life that's not dependent on somebody else, and I'm very active and I'm really happy, it's not disability at all. And then that is what has to be evaluated as disability. So these two go hand in hand. So what is disability? How do you conceptualize disability as an individual, even though you are a person who's supposed to be qualified to provide disability services? And what is the system that is actually available in your setting to appreciate this conceptualization and whether you can work with the system or you have to work towards making the system convert itself to understand and conceptualize disability as what you have conceptualized. So those are the two key things that I think it's very, very important and essential. Last but not least, I would say that look at something that is relevant to the context. So we can talk about disability and we can talk about the system, we can understand it. However, to contribute, you have to look at what is the gap in science that's there in disability. And there are so many gaps that you can point out, but stick to the gap that can be easily addressed. So we talked still about prevalence and incidence of disability or different disabling conditions. However, what is more important is how to support those who are actually there. So in India, we still say that it is only 2.21% of disability that we have. However, globally, it's accepted that every country will minimum have 15% of disability within the country as prevalent disabled population. So you are actually looking at things that we already know. We know that there's too much of underestimation of the problem and the burden of disability in many countries. However, focusing on that part is relevant. I'm not saying it's not relevant, but when it comes to helping and supporting them to become an economically productive member of the society, that is what is more relevant compared to looking at what is the magnitude of the problem. We know the magnitude is big, but let's move on and then see what is possible to contribute to them and then ensure that they are also economically productive and then contributing to society. So when you start working towards persons with disabilities, I would definitely say that the focus should be on relevance, especially on low and middle income country context compared to other aspects, which might be relevant, but the priority must be given to something that's very, very critical for a disabled to actively contribute as a productive member of the society.
Thank you so much. That was a truly incredible answer. And it actually made me think a lot of things differently, and it kind of motivates me also to think a little bit differently in terms of what I have actually learned and how I need to implement that. So I think another message to probably young healthcare professionals who are just starting out is that think about what the system really means to you, think about what disability means to you, and think about how you can reform it rather than just going with the flow and letting things be as they are. And I think that's one of the things I have been trying to do. And I think you've been an incredible and true amount of support for me. So thank you so much. So thank you so much for this.
My pleasure, Stuti. I wish you all the best for this project as well as any projects related to disability in the future. All the best.
Thank you so much, sir.